Welcome to everybody who's joining us. We're going to just wait a couple of minutes to allow everybody to log in and get connected, and then we will begin the webinar. It's lovely to see everybody again. It's been a while since we had a EPI-WIN webinar, so Happy New Year to everybody who we've not had the pleasure of saying that to yet, even though it's February. First day of it. Brief reminder to everybody that we will have a time for questions and answers at the end of the webinar. So if you do have them, please submit them through the Q&A function in Zoom, and we'll try and get to as many of those as we can. At the end, we also received some over email, so we will be answering those too. So thank you to those folks who submitted those questions. I can see people are still joining. We'll just give it another minute and then we'll get started. As always, we're recording and live streaming to YouTube, so we'll be able to share the links to those resources with everybody after the webinar. And we have a huge diversity of countries where everybody's coming from. It's wonderful. All right, so welcome everyone. I think we'll get started now. We have only 1 hour and everybody's busy, so we want to try and maximize the time we've got. So warm welcome to you all. This is the first EPI-WIN webinar of 2022, and we will have an update on SARS-CoV-2 variant of concern, Omicron. We have today with us Dr. Sylvie Briand, who is the Director of the Department of Epidemic and Pandemic Preparedness and Prevention here at WHO headquarters. And we also have Dr. Boris Pavlin, who is the Team Lead for Field Epidemiology and the COVID-19 Response EPI-Pillar Lead. So Boris, Sylvie's been on these webinars before, but I don't think you have. So it's really wonderful to have you here with us. And Sylvie is also going to introduce some of the other team members when we start. So as per usual, we do have simultaneous interpretation into French. So if you prefer to listen in French, you should be able to find that at the interpretation button down at the bottom. I'm going to leave it there and hand over to Sylvie, who will give the first presentation. Over to you, Sylvie.
Okay. Thanks you very much, Sarah, and Happy New Year to everyone, or Happy new lunar year as well. So it's great. This period of the year we can celebrate many things. So and thanks a lot to all of you to be with us today. We started EPI-WIN, and the pandemic has shown us how valuable it was to have a special channel to questions and concerns. So I think this has been a great experience, a great journey for 2 years, and so I just would like to thank you all for having attended those.
Sylvie, you've gone on mute.
No, I've been disconnected and reconnected. So next slide, please. So, and just this is just to show you how active the team has been during this pandemic, and we have worked across all the WHO, and so it's really a teamwork, but also an example of great collaboration from many regions, many countries in the world. So I think we see very often in the media what the fragmentation in this COVID-19 response, the tensions and so on. But I think it's worth sometimes just to highlight that there are also a lot of topics and areas where there is great collaboration. There is also a lot of solidarity and a lot of good things that have happened. And I think sometimes it's good to highlight also this kind of things, because otherwise we end up with a bad impression of what has happened. But I think there have been a lot of very beautiful things and experience happening as well throughout this pandemic. So I would like to thank you all as well, because you have been part of this, and I think it's worth to celebrate also this collaboration. Next, please. And I would like to give a special thanks to my colleagues. There are many more people who work behind the scene also during those 2 years. Some of them came and left, but the result is there. We have now so many products on our website, and so many great networks that have been built throughout this pandemic. So I think the reality is there to show that it was a great experience. But thanks a lot to all of you behind the scene. And Sarah mentioned that new name of our department. Actually, it's the same as before, but we just changed the name because we wanted to show that the focus of the department is really epidemics and pandemic preparedness. And this is what we do, and we will continue for the years to come. And we hope that this pandemic will be over soon, so that we can concentrate fully on better preparedness in the future. Next, please. So I will now address the purpose of this webinar, which is talking about Omicron. So as you know, Omicron was first detected in South Africa in November, and immediately sequenced, and researchers and virologists immediately realized that Omicron was quite different from its predecessors. And its predecessor means the other variant of concern, alpha, beta, gamma, delta. And the difference was in this genetic sequence, especially on the spike protein, which is a spike protein. This is a protein that helps the virus to bind to the human cells and then penetrate the human body. So these differences are important for the behavior of the virus within human population, but also because of the reaction of our body against a new variant. And this is what I will talk about in the next slides. Next slide, please. Yeah, thanks. And so because of this difference in the genetic sequence of Omicron, and also the impact on the proteins of the surface of the virus, it seemed that Omicron shows preference for infecting and replicating in the upper respiratory tract, compared to Delta or other variant of concern, while immediately going into the lungs and producing pneumonia. So, which means that Omicron also, we have seen this, and Boris will talk much more about it, but seems more transmissible and provides different symptoms than the other variant of concern. For instance, it seems that we have much more upper respiratory symptoms, runny nose, and so these are the kind of things that we had seen less in previous variants. But also the fact that Omicron has less capacity to infect lung tissues, or is more prone to stay in the upper respiratory tract, means also that we have seen also less severe respiratory infection of the lungs with Omicron than with other variant of concern. Next, please. So what we have observed, of course, since the emergence or since the detection of this virus is that we have seen a significant increase in growth rate of Omicron in laboratory, and so meaning that it multiplies quite fast. We have seen also from some studies in household that there is an increased risk for close contact to become a secondary case with Omicron. And the percentage varies depending on the studies, but if you compare from Delta, for instance, with Omicron, it's between 10 to 30% more risk compared to Delta. So, and we have also seen, of course, an increase of number of people infected by indexes compared to Delta, which means that these are studies, but it's confirmed that Omicron is more transmissible and more contagious than previous variant of concern. And we see also that this increase in number of cases and the number of people who are infected by Omicron is probably due to two reasons. The first one is that this virus is a bit different. So our immune response or the body doesn't immediately recognize this new variant, and so can be infected. But after some time, of course, our immunity kick it out. But also the fact that Omicron is also much more transmissible intrinsically, and this, therefore it's more contagious. Next, please. So, because Omicron is spreading fast and also more contagious, we see that many countries are reporting a new wave of infection. And this wave is usually much higher than previous waves because the number of cases is exponentially growing and in a very short period of time. Because we see also in certain countries that the wave is already decreasing, and people after a few weeks they see that the number of infection is decreasing, and the wave is passing. So, but during those waves, when now we observe what has been happening in those countries which have experiencing the first wave of Omicron transmission, we see that. The number of hospitalization has been much lower than we would have expected, given the number of cases, and also the number of very severe cases that require ICU is much lower as well. And we see less deaths of this. But we still see a quite high number of hospitalization. Why? Because we have a very high number of cases. And so even if you consider, for instance, that among all those cases, only 10% of them will be hospitalized. If you have 10,000 cases, 10% means 1,000 cases. And it's still a lot of people. For instance, if you have only 100 beds, you still have many more people that require a hospital bed than what you can afford. So that's why WHO has always been issuing notes of caution to the countries, because even if Omicron is less virulent than previous variant of concern, still, because of the number of people that will be infected, you can still have a wave of hospitalization that can be worrying in certain places. So that's why we need still to remain cautious, even if we can also be happy that because Omicron is less virulent. Next, please. Also, what happens with the tools that we had in hands? As you know, since the beginning of this pandemic, the research is going fast to find new vaccine, new therapeutics, and also new ways of countering this virus. So vaccine is one of the major tools that has been used now for more than 1 year. And we are very worried when we see a new variant emerging that the vaccine we have in hand may be less effective. So with Omicron, this is what we see. It seems that the effectiveness of the vaccine against Omicron variant is less effective than what we have seen for Delta. However, we see that the vaccine are still good tools, and they still protect against severe disease, hospitalization, and death. This is why the recommendation to use vaccine has not changed, because it's still an excellent tool that we have to protect the people who are more vulnerable to get severe disease. And I mean the elderly, the people with underlying conditions, and the people who are exposed to very to a high exposure of the virus who can still have a severe disease. So we are continuing the research, trying to understand better how Omicron infects the human body, how our immune system is reacting, and how vaccine can help us to complement natural immunity to ensure that we are even better protected against this new variant. Next, please. So this is to just reiterate that some people are more vulnerable, and this is an observation of the reality. And so that's why we think that it's important to protect those people so that they can, even if they are infected, they are not developing a severe disease. They will not be hospitalized because they don't need it, and they won't die. So that's why elderly are still are at risk of having Omicron, of course, being infected, but also severe disease. And there are other people, like obese people, people with underlying conditions such as hypertension, diabetes, cardiac disease, chronic lung disease, cerebrovascular disease, dementia, mental disorder, chronic kidney disease, immunosuppression, cancer, HIV/AIDS, and pregnancy, especially pregnant women with one of those underlying conditions. So those people are more at risk. So it's important that they are better protected as well. Next, please. And finally, is also the people who are exposed to a high viral load at infection. And because if you are inhaling loads of viruses at once, you are more likely probably that some of those viruses goes into your lung, and then you have a risk of develop severe disease. So we have discovered at the beginning of this pandemic that certain situations are more prone to give an intense infection at once. And therefore, even young people without any underlying factors or comorbidities can have severe infection if they are in this type of setting or situations. And so those situations are close space with poor ventilation, with many people, where physical distancing is not possible, and where you will have, of course, in the air a lot of viruses, and so you are more likely to inhale a big load of viruses and then have a more severe disease. So that's why we advocate for continuing to maintain some personal protective measures in those settings, because it's the best way to prevent infection. Next, please. Yes, thank you. So this is just to remind you of those preventive measures. If you are unwell, stay at home, because then you prevent transmitting the infection to others. Keep a physical distance where possible, because this is also making it more difficult for the virus to spread from one person to another person. Open the window, because fresh air also make it difficult for the virus to stay and to remain in the air. Try to cough and sneeze into a bent elbow or a tissue, because this also reduce transmission. Wash frequently your hands, because you know that the virus can stay on surfaces. And if you touch the surface with your hand and then touch your face with your hand, you can get infected. So continue to wash your hands. It's very good. It prevents you from being infected from Omicron, but also many other viruses, whether it's respiratory viruses or other type of viruses, for instance, viruses producing gastroenteritis. So washing hands is in any case a very good practice that protects you from many things. And when indoors, avoid crowded or poorly ventilated area and wear a mask, well-fitted mask when it's impossible to avoid the other situations and you cannot have a physical distancing, of course. Next, please. So this is in a nutshell what we know about Omicron and what you can, as a summary. Omicron is highly transmissible. Omicron appears to prefer infecting the upper respiratory tract and give, therefore, upper respiratory syndrome. Vaccines protect against hospitalization and severe disease and death. But there is still an increased evidence of immune invasion. So it means that even if you are vaccinated and fully vaccinated, you can still get Omicron. But fortunately, you are much less likely to get severe infection and being hospitalized. In places with high population immunity, and whether it's due to vaccine or to natural immunity, we have seen less hospitalization due to COVID-19 infection. We see that older persons and those with underlying condition are still at risk to get severe disease, so they need to get better protected and observe, of course, the personal protective measure as much as possible. We see a lot of mild infections, and so people with mild infections still, please stay at home if you are unwell, because it helps to reduce transmission. And measures such as wearing a well-fitted mask properly, keep physical distancing, and other personal protective measures help to reduce transmission as well. So we need to continue to observe them. Next, please. Yeah, so many people are asking what will happen next, and we don't know. We don't know because it's very unpredictable. COVID-19 is a new disease, and so we are still learning about this disease. What we know is that we have seen the emergence of many variants in the beginning of the pandemic, so we can anticipate that there will be more variants. But how different will there be from Omicron or previous variant of concern? We don't know. What we see currently is that Omicron, because it's highly transmissible, is somehow becoming the dominant variant. And gradually we see that Delta, for example, is less transmitted and may disappear maybe in the future, but we don't know. So that's why we need to anticipate any kind of scenario. But next, please. In a nutshell, we think that there are three scenarios. We don't know which one is the most likely, but of course we can hope for the best and get ready for the worst, just to not be surprised and be able to respond again. So the scenario one is that we see Omicron evolving or a new variant emerging, but a milder variant, still very contagious, but producing a mild disease and nearly no severe disease. And this virus will then be like the other four endemic virus that we have, endemic coronavirus. So this scenario is likely, but we just don't know how long it will take to see this happening. The second scenario is more a scenario similar to what we see for flu with recurring epidemics. And so because the population has already some immunity, is not naive, they have the population has immunity because the population has been vaccinated or has met already the virus. So nobody is really naive, but still the virus can produce severe disease in people with underlying condition or vulnerable group, as we have seen with Omicron. So when we have this kind of outbreak, it's important to continue personal preventive measures and of course, a continued vaccination of at-risk group with a good vaccine as much as possible. And the third scenario is that we have a completely new variant that emerged, and so we don't know what would be this characteristic. We hope it will be a mild virus, but it might be a virus similar to Delta, for instance. And in this case, we will need to update the vaccine composition. We'll need to adapt our measures and also revisit a little bit the preventive and the response measure that we have put in place to make sure we can control this new wave of infection as we have controlled the previous wave of infection. Next, please. I think it was my last slide, so I just want to thank you and give the floor to Boris for the next presentation on the epidemiology. Thank you very much.
Thank you very much, Sylvie, for that. And yes, really happy to welcome Boris. Thank you for taking the time, and the floor is yours.
Great, thanks. Let me just share my slides. Okay, do you see my presentation?
Not yet, no.
Try that again.
Yes, it's coming.
Okay, great.
We see it. Thanks, Boris.
Okay, so good morning, afternoon, and evening. I'll give a brief update on the epidemiology of the Omicron variant. I'll be going into a bit more detail on some of the topics that Sylvie already covered. The key messages here being that globally, the number of cases of COVID-19 has been increasing, driven by Omicron, that Omicron is now present in almost every country, that Omicron has a significant growth advantage over Delta, that the relative risk of severe disease due to Omicron appears to be lower than against Delta, but it is not mild, that large Omicron outbreaks are showing the potential to overwhelm health services, and then finally that the BA2 sublineage of Omicron is overtaking BA1, but does not show cause for alarm as of now. Globally, you can see that the number of reported cases has risen to unprecedented levels in a very short period of time, as shown in the colored bars, which are stacked by different colors for the different WHO regions. This peak is almost entirely attributable to the spread of Omicron, set against a backdrop of holiday festivities in much of the world. The incidence of new cases has slowed in the past week, and it looks like this wave may be cresting, although it's important to remember that behind these global numbers, some countries are very much on the upswing of their Omicron curves. Of note, reported deaths shown in the blue line have not had a commensurate increase, even after taking into account the usual lag between case onset and death. Looking at the epidemic curves by WHO region, you can see that the spike in cases has been replicated simultaneously in all regions, which is something we have not seen previously with other variants, further attesting to Omicron's tremendously rapid spread. You can also see that in the Africa region where Omicron was first detected, the peak has passed almost as quickly as it began, and deaths have peaked as well at a much lower level than previous waves. This is a map showing the proportion of Delta and Omicron variants in the last 30 days using GISAID, the global sequencing database. Darker blue means more of that variant, with the Delta in the top panel and Omicron on the bottom. The other variants are basically no longer around. Here we're only showing proportions for countries with at least 100 sequences in the time period. So that's why some countries are in tan, which indicates that the Omicron or Delta are present, but not showing the proportion. You can see that Omicron is dominant virtually everywhere where we have good genomic data. It's worth noting that there are several component lineages, as I just alluded to, or branches of Omicron's evolutionary tree. These are BA11529, BA1, BA2, and BA3. I'll talk more about BA1 and 2 at the end of my presentation. This is another way of looking at how Omicron has taken over the variant landscape. Each of these graphs is a different country with a relative proportion of a given variant shown over time from left to right. When Delta came along, it slowly replaced other variants before the other variants that came before it. However, now you can see that in all countries assessed, Omicron, shown in green, has rapidly outcompeted and replaced Delta. A few countries still have some significant amount of Delta, but we expect them to be overtaken by Omicron there as well. This is a figure showing the relative speed compared to Delta at which Omicron is transmitting in the community. This is known as the effective reproductive number, or RT. Anything more than a 0% shows Omicron having an advantage over Delta. The top panels show all the studies, but the bottom panels are the summaries that you can focus on for each of the WHO regions. You can see that across the regions, the estimates are fairly similar, around 200 to 300% higher growth for Omicron versus Delta. Now this expansion of Omicron could be potentially explained by one of two processes, as Sylvie said. It can either be naturally more transmissible, so just it spreads easily because of the way the virus is, or it could be not faster per se, but better at evading people's immunity from vaccination and prior infection, in which case it could still outcompete a previous variant like Delta, which isn't very good at evading prior immunity. So to know which factor is really responsible, we'll have to look at additional data momentarily. Here you can see some vaccine effectiveness comparisons between Delta and Omicron. On the left panel, you see the vaccine protection against getting symptomatic disease with Delta in black circles and the data for Omicron in gray circles, showing significantly reduced effectiveness. However, if you look at severe disease on the right, you can see that Delta and Omicron are much closer. And the last circle I showed is the effectiveness for 2 doses, with some worse performance for Omicron. But after a 3rd dose, the protection is almost identical for severe disease, which is great news. Now to look at the other side, the transmissibility, with one side, is it more transmissible? We looked at a study in Denmark in which secondary attack rate was compared in households where the source case was infected with either Delta or Omicron. Secondary attack rate is basically your chances of getting infected if someone in your house is a case. If you look at the unvaccinated group in the first column, you can see that the odds ratio, or the relative chance of getting infected, is not significantly different between Delta and Omicron households. If it's exactly 1, it's no difference. And actually the range of possible estimates crosses 1. But perhaps it's leaning towards being more likely to be infected if your source case is Omicron. However, if you look at the vaccinated contacts, you can see that the ratio increases very significantly for cases of Omicron. In other words, Omicron is very successfully breaking through the infection protection of vaccination. Note that these figures do not indicate that being vaccinated increases your chance of getting Omicron as compared to not being vaccinated. This is not the case. It's just that vaccination is not as protective against infection with Omicron as it was for Delta. That's vaccination. Now, if we look at the risk of reinfection in those with natural immunity due to prior infection, we see a much higher reinfection risk for Omicron than for Delta. Oops. When further broken down by vaccination status, you can see there is a difference between those who are vaccinated and those who are not. For infection only here, we're looking, but it is not a big difference. So overall, we can conclude that a huge part, if not all, of Omicron's growth advantage is due to its ability to break through prior immunity from both natural and vaccine-derived immunity, rather than being more transmissible intrinsically as being the main driver. However, much more important than the effects of immunity on infection are whether Omicron is more or less severe. Here you can see a few graphs showing the alignment of cases, hospital admissions, intensive care admissions, and deaths across the 3 major waves of SARS-CoV-2 infection in South Africa. South Africa has a relatively low vaccination coverage, but has high natural immunity from past infection. You can see that while cases, which are shown in blue, were higher than previously, and hospital admissions, which are shown in red, rose somewhat, but not as high as previously, the ICU admissions, shown in light brown, and the deaths, shown in dark brown, remained relatively much lower. So Omicron is not as severe, but obviously it is anything but benign, as it still led to an increase in ICU admissions and deaths nevertheless, because of the huge numbers of cases, as Sylvie said. Here's an even more dramatic example of the decoupling between cases, hospitalizations, and deaths from the United Kingdom, a country with much higher vaccination coverage than South Africa. Many, many cases, but relatively very few hospitalizations, ICU admissions, mechanical ventilation, and death. And here's one for Argentina, another country with very high vaccination coverage. However, before we celebrate, let us remember that such massively widespread transmission, even in proportionately less severe disease, can result, as Sylvie said, in overwhelming of health services. Here are data from New York State in the United States, where you can see that although there has been clear decoupling of cases and severe cases, the number of hospital admissions still far exceeded their previously highest number. Excuse me, which happened during the Delta wave. So not only is Omicron's widespread transmission putting a burden on hospitals, but the widespread transmission is also resulting in many healthcare workers and other essential staff to miss work, either due to illness or because they are quarantined contacts, resulting in critical staff shortages. So this is why, all in all, we continue to assess the global risk of Omicron as very high, despite its lower severity than previous variants. Now let me turn to the sublineages of Omicron BA1 and BA2, which are by far the most prevalent of the sublineages, with, as of now, BA1 being by far the more common. I won't go into the genetic differences between the two, but both have many mutations as compared to the original virus. Repeating that earlier analysis of relative transmissibility while looking at just BA1 and 2, we can see a relatively higher growth rate for BA2, but not as dramatic as the difference between Omicron and Delta. So BA2 does appear to have the potential to replace BA1. Here's some more evidence of BA2's advantage over BA1. In household secondary attack rate studies in Denmark and the UK, there was a modestly higher likelihood of getting infected if your source case had BA2 than if they had BA1. So far in the real world, this has played out as BA2 already becoming dominant in the Philippines, Nepal, Qatar, India, and Denmark, and several other countries soon to likely become dominant. But does this have any major real-world consequences? Let's look at the evidence on severity. So far, and we don't have lots of evidence on the differences, but there doesn't appear to be any difference in severity between BA1 and BA2. This is evidenced by direct clinical comparisons in Denmark, the first country where BA2 overtook BA1, and also looking at other countries where BA2 is now overtaking, we're not seeing any higher bumps in hospitalization than expected. As for vaccine effectiveness, the vaccines so far seem to be equally effective against BA2 as they do against BA1. 63% and 70% there might suggest that BA2 has higher, that its vaccines are more effective against BA2, but I would point out that the confidence intervals are overlapping for these. So for now, it looks like there's basically no difference. So to summarize, Omicron is still very high risk globally, even though it is less severe. Vaccination is profoundly protective against severe disease, including for Omicron. BA2 is rapidly replacing BA1, but its impact is unlikely to be substantial, although more data are needed. I would say unlikely to be more significant than BA1 in Omicron in general. And some general principles to keep in mind. getting infected to create immunity is not a viable strategy because there will still be many severe cases and deaths, even with Omicron, and your risk is higher than if you were to be vaccinated. Appropriate public health and social measures are still needed while we get the remainder of those who are vulnerable vaccinated. And we have to remember that in much of the world, vaccination rates are still dismally low. We also need to continue appropriate public health and social measures during this time, because doing so limits transmission and thus reduces the risk of more variants emerging. And the next variant, which will be more transmissible than Omicron because it has to be in order to become the next variant, may or may not be less severe than Omicron. So we can't assume that the worst is behind us. And with that, I will thank you, and I'm happy to answer any questions and follow up.
Thank you very much, Boris, for the presentation. There are plenty of questions in the Q&A, and I know that you've been answering some of those. And I know Sylvie's also been monitoring them too. So at some point, we'll answer some questions, but then I will ask you if there were any questions that you see a lot of repetition of, or that you've already answered that you would think would be applicable to the majority of the audience, and I'll give you a chance to do that too. So the first question, Sylvia, is for you with regards to the scenarios that you talked about. Someone is asking, is there an evidence-based document that exists about the potential scenarios for 2022 of the evolution of the pandemic at a global level? Sylvia, do you want to take that one?
Yes, thank you, Sarah. No, there is no evidence-based document because it's a new disease. So we can look at the past and try to understand how it could evolve. As Boris said, it's very likely that the next variant will be more transmissible so that it can overcome the existing variant. But regarding virulence and severity of disease, I mean, this is something that is completely unpredictable. When we shaped those three scenarios, it was more for planning purposes and for us to understand where, having a wide range of options so that we can plan accordingly and not be surprised. But of course, we are using as experience what we know about other respiratory viruses, for instance, the influenza viruses, and all the experience we have acquired in previous years about other types of epidemics due to respiratory viruses. But so I'm not able to predict anything about the future, but I think what is important is more to look at the future to, for at least for public health community, to plan for the future, meaning that, okay, currently things are better, and I know that many countries are lifting public health measures because they want to go back to normal. That's fine if their epidemiological situation allows for it, but they still need to be ready to put in place again such measure in near future if the situation evolves and change, and if we see a new variant emerging. So it's a note of caution, I think, and as Boris said, it's not sure that the worst is behind us. We all hope it is, and we all hope that humanity has been able to overcome the acute phase of this pandemic, but we still need to be cautious about the future.
Thanks very much, Sylvie. Boris, a question for you. Do we know whether previous infection with the original strain or Omicron would protect against infection with the BA2 subvariant?
The short answer is we don't. We have yet to see any data on Omicron upon Omicron reinfection. So like I showed you, it's quite easy for Omicron to reinfect people who are infected with previous variants. And I suspect that, as with many other situations, after some period of the immune system waning, a person who had Omicron will be able to be reinfected with Omicron if it's still around. But as for BA1 versus BA2, we don't have any data, and if it would just be speculation based on the mutations at this point, so I'd rather not speculate.
Thanks, Boris. There's been also Sylvie. Yeah.
Yes, I would like to complement what Boris has said. I think you can look at our EPI-WIN slide set on immunity that we published earlier in this pandemic. And here you will notice that there are different immune barriers in the body. We have the mucosal immunity, and then you have also more humoral immunity. And so what we can test when we test immunity is mostly the neutralizing antibodies, meaning humoral response. But it's very hard to assess the level of mucosal immunity, and also very hard to assess routinely the cell response immunity. So when you see studies on immune response, obviously it's just possible, I mean, in a kind of a routine way to assess a very small part of the immune response. And that's why it's very hard to answer this kind of question: are we immune or not, and are we responding or not? Because the tests we have are costly first, and cannot provide this kind of answer on a routine basis. But what we can observe is that because of we see much less severe disease with Omicron, and many people apparently have been previously infected or vaccinated, we can assume that maybe there are other part of our immunity that is still very important and able to protect us. So this is just to highlight a bit the complexity, and there is no definite response on this, but we probably have still a good immune response. And there was a question in the chat I didn't answer thoroughly because it's a bit long to write the answer, but it's very likely that our mucosal immunity is quite strong against Omicron, even if it cannot be detected routinely by test. Over.
Thanks very much, Sylvie. More questions on immunity. Is WHO collecting the information on how long immunity lasts following vaccines and boosters versus natural infection? Who'd like to take that?
Yes. Yes, many groups are monitoring this, but as you know, it's a new disease. So for natural immunity, for instance, now there are studies following cohorts. So initially people said, okay, it lasts 6 months. Now we have recently a study has been published in Nature, I think, that it says that it lasts 1 year. So clearly we are still learning about natural immunity and how long it lasts. And as the time goes by, we will discover that maybe it lasts even longer. But so this is the latest data. Regarding the vaccine immunity, again, for vaccine, because vaccine elicits antibodies, and so we are only measuring neutralizing antibodies to say if the vaccine lasts long. And so what we see in certain studies is a decline of this immune response. And this decline is measured about the vaccine response. And so we see that with certain vaccine platform, it seems that the immune response, in fact, is declining after a few weeks. But depending on the studies, we have a lot of different timing. And also depending on the vaccine platform, it may vary a lot. So it's hard to give you a simple answer to this question. But we see that vaccine immunity indeed is decreasing. So does it mean that we need to get repeated boosters? Not necessarily. We have a new expert group called TAC-COVAC that has met recently and issued a statement. And experts think that having a strategy, a vaccination strategy based on repeated boosters, it's not necessarily the good way forward. And we need to rather think about how can we improve the vaccine so that we don't need to have repeated boosters. So currently, this is the reflection we have. It's more to improving the product rather than recommending member states to boost everybody every few months. In addition to the cost and the burden that represent a repeated boosting strategy, there is also a legitimate concern about vaccine equity. And we think that it's more important currently at this stage of the pandemic to vaccinate and to provide primary doses to people who are vulnerable in the world, rather than boost people 4 times or more in a rich country where vaccines are available. Thank you.
Please, Boris, over to you.
I feel I should address a slide. I see a lot of questions related to the slide I showed about secondary infection in unvaccinated versus vaccinated people. And I wonder if I could flick that up and talk through it again.
Please do, go ahead.
Okay. Okay, let me just see. I just want to make this big again. So this was the slide that a lot of people were confused about, rightly so, in which I stated that.
Boris, I'm sorry, we don't see the slide.
Okay. Try again. Ah, I see.
Great.
Okay. So so the point here was that in a secondary attack rates are, you have a person in the house that has an infection and what are your chances of getting it? And they looked at Omicron versus Delta primary case, what are your chances? What they showed was that in unvaccinated people, in other words, people who don't have any, where the vaccine doesn't influence the question about whether Omicron or Delta transmit better, there was a slight advantage, statistically insignificant advantage of Omicron over Delta, which basically means they both transmitted about equally when the rest of the people in the house weren't protected by vaccines. Now, if you look at people who were vaccinated, so people who have only completed their primary series in general, especially after some time, start to look like unvaccinated people again. But people who are recently boosted, boosters are a recent phenomenon, are well protected by vaccines, okay? But what this shows is that even those who are highly vaccinated, let's look at the booster column, Omicron was able to break through that in a way that Delta was not. But so Omicron's real advantage came in only when people were vaccinated, that it was getting through people who were vaccinated better than Delta could do that. This is not the same as saying that being vaccinated gives you Omicron, or that being vaccinated makes you more vulnerable to Omicron. Being vaccinated makes you less vulnerable to Omicron, and it makes you less vulnerable to Delta. But it does better at protecting you against Delta than against Omicron. And so the gap between Omicron and Delta opens up. So Omicron is not doing a good job. Vaccination is not doing a good job of preventing infection from Omicron, but it does continue to prevent severe disease almost as well as it did for Delta in the previous ones. So vaccination remains crucial.
Thanks very much for clarifying that, Boris. There have been a lot of questions about the incubation period for Omicron. Has that changed? Many countries are shortening their quarantine periods for contacts, etc. What is the evidence on the incubation period?
There is some evidence emerging that perhaps Omicron has a shorter incubation period, but it doesn't seem to be dramatically different. Delta already seemed to be, having a little bit shorter incubation period. The reason that many countries are going to shorter quarantine is primarily an operational one. With so many people infected with Omicron, and also with the resulting disease being less severe, many countries simply don't have the resources, or they do not consider it appropriate to, in the balance between the harms and the good of quarantining people, to keep them in quarantine for as long. It's simply impossible for many countries to do appropriate contact tracing and quarantine in the current scenario. We're actually working on some guidance to help countries through that.
Thanks, Boris. We only have 2 minutes left on the webinar, and I know there are many questions that have remained unanswered. So I'm going to go to you, Sylvie, and then back to you, Boris. If there are any in the Q&A, if you want to skim through that you think are really pertinent and need to be addressed, I'll come to you. But Sylvie, you've been monitoring the chat. Did you see any that you'd specifically like to answer?
Yes, I would like to. There was a question on Omicron and airborne transmission. So I think this is an important question, and I know that many people are very concerned about this. So I would like to highlight two things. The first thing, that airborne is a word that has been used frequently during this pandemic, but has a different meaning for technical people and researchers and other people who are not necessarily specialists in virology or those infectious diseases. So within the scientific community, we have had a lot of discussion about the transmission of SARS-CoV-2 virus that is producing COVID-19 disease, trying to understand how this virus transmits, under which conditions, and so on. And these are very technical consultation, and for scientists working on those questions, of course, they differentiate droplets and airborne transmission, because these are things that we measure in laboratory, and we try to see if the virus, depending on the size of the droplets, how far it goes, how long it stays in the air, and so on. So these are studies that are done in laboratory, and based on those studies, we decide how is it airborne or not airborne, and so on. But this is a set of studies and concerns that are really technical, really scientific, and it's still in the making. We are still studying it. But what are the implications of those discussions on all of us? Actually, it doesn't make much difference, because still we know that it is a respiratory virus, that it will transmit from person to person. And so the preventive measures that we are recommending are valid. It means that it's better to wear a mask. It's better to, especially when you are in closed setting, it's better to open the window. And there are things like that that can really reduce your risk of being infected. So I think it's important to differentiate those two type of conversation. One conversation on the science, which is very important and it's still ongoing, and people are discussing it very thoroughly. And what is the impact on our lives, and how can we implement a preventive measure that protect us from getting infected or from getting severe disease. And I think we should differentiate those two conversations. Otherwise, it becomes a bit confusing, and it increases the fear and the anxiety. In my opinion, it's increasing the anxiety unnecessarily, because we do have the tools to protect ourselves, and provided we use them wisely and in the right situation, I think we are pretty good, and we can reduce transmission. Thank you.
Thanks very much, Sylvie. Boris, any final questions that you'd really like to answer?
Nope, just trying to furiously answer as many as I can in the chat.
I can see you typing away. Thank you. So I'll just say to everybody, there's been a lot of questions. Please share these slides. We will do so after the webinar. We'll send both Boris's and Sylvie's. And thank you to both Boris and Sylvie for the presentations and for answering the questions. And I'm sorry that we didn't get the time to answer them all, but I'm sure there will be follow-up webinars in the near future, and we look forward to having those. So Sylvie, yes.
Yeah, and just one thing, I think, thanks for your questions, because it helps us to understand what are your concerns, and we will address them in future EPI-WIN slide set. It helps us also to message and to generate, translate the science we have from various studies into something that is more digestible for all of you. And so thanks a lot for helping us to do a better work. And thanks for your attention.
Great, thank you. And I hope, Boris and Sylvie, you've looked at the chat and seen all the thanks from people. So I echo that, and I wish everybody a really good rest of the day wherever you are in the world. And thank you for joining us, and we will see you again soon. So thank you. Bye-bye.